The neuro lecture begins with, first of all, an assessment of the variety of types of tools that you would use as far as assessing a neuro patient for complications and those types of things. Just a reminder to review your pathophysiology on the neuro system before starting the lecture, so the terminology is more familiar. Refer to your textbook for that. When we look at an overview of different neurological disorders, it encompasses many medical diagnoses. There are over 1 million people that suffer brain damage and insult yearly. The ranges for patients that are neurologically impaired or that have had a neurological insult can range from mild to severe. And it can be from an injury that could be part of the problem, and also it could be due to degenerative types of diseases. So if we look at the different types of things we would assess with a neuro patient, one of the very first things we would do is to check that patient's level of consciousness. This slide looks at the different levels that we assess when we do a neuro assessment on our patients. So all of you are familiar with the patient who's awake and alert and oriented times 3. Some of these other terms might be new. The patient that is drowsy tends to act very lethargic, has a short attention span, may only respond when aroused through verbal stimuli. Stuporous patients are very apathetic and obtunded and aroused typically only to very vigorous stimuli, perhaps even painful stimuli such as nail bed pressure, that type of thing. And the comatose patient can be either from a light state to a very deep comatose state. Typically, these patients have no verbal response, withdraw from pain, and do some posturing that we're going to talk about in some of the later slides. Some reasons for changes in level of consciousness. It could be due to multiple trauma and brain injury, and those are listed to the left, such as concussion, contusions, and hematomas. Could be due to some sort of an infectious process such as meningitis. Tumors of the brain. Could be a patient who suffers from a seizure disorder, an elderly patient with Alzheimer's syndrome, or it could be due to encephalopathy, for example, from diabetic ketoacidosis, acid-base imbalances, hepatic disorders, an anoxic insult to the brain, or from toxicity from drugs or alcohol. Reasons for level of consciousness continued also include metabolic alterations. So, for example, fluid and electrolyte imbalances can cause this, acid-base imbalances, anesthetics, and systemic conditions such as low oxygen levels and ischemia. Patients with increased intracranial pressure also will have a changed level of consciousness, as will those patients who've suffered from stroke, hematoma, infections, or demyelinating types of disorders, which we're going to talk about later in the neuro lecture. Acute alterations in orientation include acute confusion, which with this one the patient may have impaired judgment and may need cues to respond to commands. The patient is unable to think rapidly or clearly, so a lot of times this is due to electrolyte imbalances or fluid deficits or fluid overloads, or it could also be due to low oxygen levels. Delirium, the patient who suffers from this is very confused, has a rapidly altered mental status, is very disoriented, and may also have personality changes. They have hallucinations, which are misinterpretations of the sensory impressions, and this could be due to a variety of different things. It could be due to meds, overdoses of medications, fluid imbalances, and those types of things. Dementia is a impaired intellectual functioning where memory, learning, judgment, and problem solving are all altered. It's usually progressive, develops typically very slowly, and is chronic. And this particular type of alteration in orientation is irreversible. So dementia is not considered just a normal part of aging. Sundowner syndrome is something you may have heard before. This occurs typically in older hospitalized patients. Sometimes you'll also see this in nursing homes. And the symptoms you see with this include agitation, confusion, behavioral changes, wandering behavior, and typically when it starts, is when, just like it sounds, when the sun goes down. So late afternoon and early evening. And a lot of times what contributes to this particular problem is sleep disturbances, sleep apnea, patients who have decreased visual acuity along with those other problems I just mentioned, and also if there's a lack of structure in the afternoon and early evening. So that's typically what's seen with these patients. Another assessment piece that we would do with our patients who we are suspecting a neurological problem is to check if that patient has any pain in their head. So in other words, do they have any headache or any other types of pains? So when we look at a headache, it results from an interaction between the muscles, the nerves, the blood vessels, and the pain-producing substances in the brain. And so typically a lot of times migraine headaches are one example of headaches, and one substance those are associated with are an abnormal metabolism of serotonin, and that results in painful dilation in the arteries of the brain, causing severe headaches. Other things that we can see is you may also see patients have headaches when there's displacement, inflammation, or dilation of nerve endings with the brain. Probably it's about 45 million people suffer from headaches, and as we all know, they can range from very mild to very debilitating. This lists some different types of headaches. Acute could be related to a ruptured aneurysm situation. Patients will say that that's the worst headache that they've ever had in their life. Sometimes it's a headache so severe it knocks them to the ground, those types of things. Chronic headaches can fall into different categories. We mentioned migraine headaches a little bit ago. Typically, that's due to a chemical change of serotonin. Some patients have very severe symptoms, and some have milder. It can really vary from patient to patient, but typical symptoms associated with migraines are nausea and vomiting, fatigue, photosensitivity, where the light bothers their eyes, and irritability. Cluster headaches are typically more common in men, where migraine headaches are more common in women, and typically the headache will be unilateral. Patients will complain of a burning pain behind and around the eyes, and this can last from several weeks to several months with these types of patients. So this just gives you a quick overview of some of the different types of headaches that we see. When we look at migraine headaches, those are typically found in women who are between 20 and 35 years old, and a lot of times the onset is during puberty. So there is a hormonal component to migraines that sets them off. This gives an example of different types of hematomas that are seen in patients. Just as a reminder, the three coverings of the brain, the outermost covering is the dura, underneath that is the arachnoid, and the third covering of the brain is the pia. And each of those coverings of the brain, if there becomes a collection of blood between any of those coverings, it can lead to intracranial pressure increases, headache symptoms, and changes in level of consciousness. So this slide just depicts the differences between an epidural hematoma, which tends to be an arterial bleed, and typically what happens here is there's been some sort of a laceration into the middle meningeal artery. The bleeding is very quick. This can become a very serious and a very intense situation very, very quickly. So patients, if they pick up that they do have an epidural hematoma on an MRI, particularly after an injury, those are the patients that are going to be rushed immediately to surgery. A subdural hematoma tends to be more of a slower type of a bleed. This is because it's due to a venous bleed rather than an arterial bleed. However, this can also cause brain damage and disability. So this would be another thing that may require surgery for the patient or some sort of a drain. Intracerebral hematomas, when we think of a bleed within the brain tissue itself, a lot of times this can be from something like bullet wound, severe stroke, different things like that. Severe hypertension can also cause intracerebral hematomas. Brain tumors also can cause this. Any type of neurological disorder from different types of bleeds or different kinds of injury to the brain can potentially cause injury to the Broca and Wernicke areas of the brain, which are the areas of the brain that control our speech and written writing and those types of things. So just a quick reminder from your patho class, Broca's area is located in the frontal lobe of the brain, and this is the center that actually controls motor speech, in other words, forming words and expressing words. Wernicke's area, on the other hand, is located in the temporal lobe, and this is needed for auditory association. In other words, the association of interpretation of written and spoken words. So if the patient has a stroke, for example, if only the Broca's area is affected, then that patient will have trouble with motor speech, whereas if the Wernicke's area is only affected, that patient will have problems with receptive speech. And then we're going to talk about there is a chance the patient may have both of these types of areas affected, and that patient will have then complications in both of those particular areas of speech. Aphasia is defined as a defective or absent language functioning. It's typically seen with damage to the left cerebral cortex, and that's because those speech centers are located in the left side of the brain in 95% of all patients. They're also seen with strokes that occur in the left hemisphere more than patients that have in the right hemisphere. And like we talked about earlier, the types of aphasia that we see can be expressive, receptive, or global. So expressive aphasia, this is the one where the Broca's area would be affected. And these patients will have non-fluent speech, will do poor repetition and naming, their writing is very poor, and these patients are very, very frustrated because they can understand written and spoken words, but they just can't seem to formulate it themselves. So if you've ever taken care of a patient that has expressive aphasia, you know how challenging that can be because these patients are very frustrated with the situation. One of the main things that helps these patients to communicate is to use a picture board. Receptive aphasia, on the other hand, is where there's a deficit in the auditory and reading comprehension area of the brain, in other words, Wernicke's area. And these patients can hear, but they're not able to interpret information that they're hearing correctly. When they talk, their sentences are typically filled with jargon, word substitution, and all those types of things. Typically, their speech may be very fluent, but may have inappropriate words in it, inappropriate content, and those types of things. Patients with global aphasia will have impairment in both of those areas of speech centers that we talked about earlier. So they will also have non-fluent speech, little auditory comprehension. They use swear words very often due to the damage centers in the areas that control speech in the brain and those types of things. And this is very common with a mid-cerebral type of an infarction. So to just do a little quiz to test your knowledge on the different kinds of aphasias, see if you can fill in the answers. Question number 1 says the most common cause of damage to the language center is, and if you entered stroke or cerebrovascular accident, CVA, then you are correct. Number 2 says Broca's area is located in the what lobe of the brain? If you answered frontal lobe, you're correct. And number 3 says Broca's area is responsible for, correct answer here is word formation. 4 says Wernicke's area is located in what lobe? And that would be the temporal lobe. And Wernicke's area is responsible for language comprehension. So if we look at some different statements, patients may say to us, let's try and decide what types of aphasia these patients are having. The first statement, the painter is operating on my leg, the patient would say that very fluently. They would look at you expecting a response from you because they think that what they've said makes perfect sense. So this would be an example of receptive aphasia. The next line down there is just a substitution for swear words. So that would be an example of global aphasia. That patient is unable to express words. Number 3 is the boxers washing all over the cats. So that's another example of jargon and words not making sense in a sentence, and that would be an example of receptive aphasia. And the last one then, go to the park, is said as a stuttering type of a sentence, and this would be an example of expressive aphasia where that patient has a lot of difficulty trying to form words. patients that have neuro injuries and different types of disorders within the brain many times suffer from increased intracranial pressure. So we're going to go ahead and talk about that next. Probably one of the most recent people that have been in the publicity that have had a neuro insult due to injury and that type of thing is the news correspondent Bob Woodruff, and he actually has made a remarkable recovery considering the insult that he had during the war and that type of a thing. So when we look at what exactly is intracranial pressure, it's defined as an increase of pressure within the cranial vault. There's very little room inside the cranial vault for an increase in the size or amount for brain tissue. So in other words, if there's edema on the brain due to some sort of an injury, or if there's bleeding within the brain due to injury or stroke or for whatever reason, anything that's going to put extra pressure within that cranial vault or the skull is going to put pressure then on the brain because there's not any room to expand. When we look at what's actually made up in the cranial vault area, 85% is going to be brain tissue, 5% is going to be intracranial blood, and 10% is going to be cerebrospinal fluid. So as you can see, you can't really change much on any of those things in order to try and keep that area down or keep the pressure down in that type of a thing. So any increase in any one of those, brain tissue edema, bleeding within the brain, or some sort of an increase in the amount of cerebrospinal fluid produced is going to increase the intracranial pressure. And if that's not resolved, then that can cause permanent neurological damage or death. So some common causes of increased ICP include edema in the brain from surgery or an infarction, could be lesions or tumors or some sort of an injury to the brain. Could be due to hematomas, could be due to abscesses or infections, could be to a patient that suffers from hydrocephalus, head trauma, or a patient that suffers from status epilepticus. There's a hypothesis called the Monroe-Kelly hypothesis that states normal compensatory mechanism. The Monroe-Kelly hypothesis states that if equilibrium does not exist in the skull, the volume of any of the three components, which we talked about on the last slide, the brain, the CSF, or the blood, increases, then the volume of the others must decrease to maintain normal pressures within the cranial cavity. So this is just showing that there's a normal compensatory mechanism for the regulation of volume within the brain and within the cranial vault or within the skull. So, for example, if you have cerebral edema, the brain is swollen, that type of a thing, due to injury or due to infection or whatever reason, something's got to give. There's only so much space in there. So typically what's going to happen is there's going to be a decreased amount of blood flow to the brain because remember the only three components that we can change within that space is brain tissue itself or CSF fluid, which that's going to be continuously produced by your body. So we really can't change the amount of that that's going to be produced. So the third component that will be changed will be the volume of blood that goes to the brain. And remember, anytime you have anoxia, lack of blood to the brain, those patients can suffer permanent damage if it lasts for a certain amount of time. Just to kind of let you know typically how much CSF is produced in the body, on the average as an adult, we make about 25 to 30 milliliters per hour of cerebrospinal fluid. So at any one time, we will typically have around 145 milliliters bathing the brain to kind of keep it coated and that type of a thing. Typically, that's made in the choroid plexus, and then what the excess that's not needed just gets reabsorbed into the venous system. When we look at children that have hydrocephalus, these children actually, if that's not treated with a shunt, these children will develop very, very large cranial cavities, very large heads. And the reason for that is because up until the age of 2, those skull bones are not fused, and so the skull can continue to expand. Adults do not have that because the skull bones have been fused, and so there is no more room for expansion within the skull. Typical increased intracranial pressure is between 5 and 10 millimeters of mercury. This can vary a little bit depending on your source that you look it up. Different textbooks have that slightly different from other textbooks. Typically anything considered over 10 is considered increased intracranial pressure. And remember, as pressure within the skull increases, the arteries and veins get compressed. This leads to decreased oxygenation and decreased perfusion and blood flow to the brain. And if this is not resolved, then this is actually going to physically shift the brain tissue. And what's going to happen is that the brain can actually herniate through the foramen magnum, which would, of course, cause death in that particular patient. So with our patients that have increased ICP, we have to be aggressive with their treatment to try and keep that pressure down. One thing we want to do is we want to bring the increased intracranial pressure down to a normal value while maintaining something called the cerebral perfusion pressure. And what this measures is actually how adequately the blood flow is to the brain. So the way we calculate out cerebral perfusion pressure is to take the mean arterial pressure and subtract the intracranial pressure, and this gives you the CPP. Normal cerebral perfusion pressure is between 70 and 100 millimeters of mercury. Anything less than 50 will lead to compromised cerebral blood flow, anoxia, and brain damage. So our goal is to keep that CPP above 70, and we know that if that's happening, then the brain is getting enough oxygen and nutrients so that there will not be brain damage and that type of a thing. The mean arterial pressure is the average blood pressure and average arterial pressure during a single cardiac cycle to provide adequate perfusion to the brain. So the way you actually calculate out the mean arterial pressure is to take the systolic blood pressure plus 2 times the diastolic blood pressure and divide that number by 3. Now the nice thing is you might have noticed this when you do your blood pressures on your patients in the hospital setting and you're doing it with an automatic blood pressure cuff. If you notice, next time you take a blood pressure in a patient, look for the MAP value. That's automatically doing the math for you so that it does that calculation. So normal MAP is between 70 and 110 millimeters of mercury. Less than 60 leads to decreased cerebral perfusion. For those patients that have sustained increased intracranial pressure, it's going to lead to compromised cerebral blood flow, permanent brain damage, possibly herniation, which we talked about earlier. And a lot of times we can pick up early and late signs and symptoms of ICP to keep it, to catch it, I should say, before that patient develops a poor sequela from it. So this next slide looks at the early versus the late signs and symptoms of ICP. A lot of times nurses will have a gut feeling on their neuro patients that something has changed or something is just not right with their patients. It may be that they're just picking up on a very, very early and a very subtle change in the neurological status. So don't ever ignore that gut feeling that you have that something has changed with your patient's neuro status. Check it out and see if it's something that needs an intervention done. If you watch the neuro videotape that's loaded under the neuro lecture area of Blackboard, you'll see subtle changes that happen with a patient that undergoes ICP changes and ends up neurologically with problems and those types of things. So I'd highly recommend to watch the video. The first 5 minutes of it is a little bit dry, but once it gets going, it does a nice scenario of what it would be like to take care of a patient in a neuro ICU that's going through changes of ICP. So if we look at those early signs and symptoms, typically you're going to see some sort of a level of consciousness change. That patient may initially be restless. The patient may just have slight changes, and then if the ICP is continued to rise, then that patient will start to be more lethargic, more obtunded. You may have trouble arousing them and that type of a thing. The patient may initially complain of a headache, be disoriented. You might note some pupil changes, changes within the vision. Patient may state that they're having double vision problems. They may act very confused or restless. And you may start to notice that the patient's having hemiparesis or hemiplegia problems. So late signs of ICP, hopefully that patient is had interventions implemented before they get to the late signs of ICP, but the level of consciousness will continue to deteriorate with these patients. They're going to have widened pulse pressures, which is the difference between the systolic and diastolic blood pressures. They're going to become bradycardic. They're going to have slower respirations with possible periods of apnea. They may develop a fever due to pressure on the hypothalamus, which regulates the temperature control mechanism within the body. And they may start to have some posturing, which we call decerebrate and decorticate posturing. And we're going to talk about that a little bit later in the lecture. That patient may progress to a comatose state. And in that case, they may arouse to only painful stimuli, or if they're in a deep comatose state, they may have no response to painful stimuli. We're going to go ahead and do a nursing situation for the neuro lecture. We're going to say we have a 26-year-old patient that was found unconscious following a motor vehicular accident and was admitted to the ER by EMS. Patient was noted to have abrasions and bruising on the face, was initially unconscious at the scene, had an IV started by EMTs, and C-spine precautions are in place. When you get this patient into the emergency room, you note on assessment a decreased level of consciousness. Patient is noted to have right-sided weakness. The left pupil is slightly dilated. Patient is noted to have some decerebrate posturing to painful stimulation. Has a Glasgow Coma Scale of 8, has a negative Babinski sign. Vital signs are as listed. That patient has an elevated systolic with a pretty stable diastolic. Patient has low pulse, low respiration, slight fever, and patient goes down for a stat CT scan, which comes back showing that the patient does have a left-sided epidural hematoma. So the reason you're starting to see pupil changes is due to pressure within the brain on that third cranial nerve. So remember, that's going to be the one that regulates response to light with the pupil and those types of things. So some questions that need to be asked is, does that patient have headache if that patient is alert, pupil changes, visual disturbances? Our particular scenario, this patient would not be alert enough to be able to tell us if he had a headache or pain. Why are we concerned with level of consciousness? Remember, the reason why is because it's one of the earliest indicators of intracranial pressure. Pupils may have changes that are ipsilateral or unilateral. Ipsilateral means that the pupils are abnormal on the same side as the brain injury or bleed. And unilateral means that both hemispheres of the brain have been affected. And we talked about earlier why that patient may have a temperature, because the hypothalamus in the brain regulates the body temp, and if there's pressure on this area of the brain, then the patient may run a fever. Physical changes in intracranial pressure include motor abnormalities. That patient may be doing posturing. We may see Cushing's triad, where the patient has increased systolic blood pressure with decreased diastolic blood pressure, bradycardia, and respiratory pattern changes. So in our particular case scenario, we are saying that the patient actually had, I believe it was decorticate posturing, and this is an example of that. With this, there's abnormal flexion of the arms at the elbows, the wrists, and the hands, and there's extension of the legs. And this is seen with patients that have serious brain injury, and it has interrupted the corticospinal pathways, and that's why you see the patient actually posturing. Typically, what they'll do is they'll posture to some sort of a painful stimulus, such as fingernail pressure, sternal rub, or something like that. Decerebrate posturing is where the patient has abnormal extension of the arms and hyperextension of the forearm. And this is a very late sign of neurological deterioration. What this can lead to is the third scenario you might find with your patient is that you might do a sternal rub or fingernail pressure with them to check posturing, and they might just be flaccid. And this is a very ominous sign if the patient has no muscular response whatsoever to painful stimuli. In our patient case scenario, we mentioned the Glasgow Coma Scale. on that particular patient was 8. If we look at what that means, the Glasgow Coma Scale is a tool that measures neuroassessment, and the patient is assessed a numerical value for 3 different categories. One is for eye-opening response, one is for verbal response, and one is for the best motor response. So as you can see, a score of 15 would give that patient the best that they could get, and that would be normal, a neurological response from that particular patient. A score less than or equal to 10 usually indicates that the patient needs emergency attention, and a score less than 3 means that that patient is in a deep comatose state and has neurological insult. This is just an example of neurological charting that you might see if you rotate back to a neuro ICU wherever you're doing your clinicals. So as you can see, it's a very detailed type of a charting specific to that type of a unit. It actually goes through the different cranial nerve functions. It goes through some different things called doll's eyes and things like that that we're going to talk about in a little bit. So in addition to your basic hand grasp and pupil response, it goes through a lot more information to do a more detailed assessment of that patient. When we look at cranial nerve response with patients and assessing the cranial nerves 1 through 12, just remember there's an acronym that's been around for a very long time. It helps you to memorize them. So you're probably doing that in your patho class, learning cranial nerves 1 through 12 and the functions of each one of those. But if you go through, each letter stands for I should say the letter at the beginning of each word is kind of an indicator to remind you what the different cranial nerves are. So you can use that acronym on Old Olympus Towering Top, a Finn and German viewed some hops, and read the speaker notes to see how you can help to remember those cranial nerves. We talked about on the charting that was a couple slides back that one type of test we might do on our patients is to do where we check for what's called doll's eyes. This is also known as the oculocephalic reflex testing. And what this does is it looks to see if that patient is responding correctly to stimuli and it looks at neurological impairment. So with this particular one, what would happen is the patient's head is turned back and forth, and a normal response is that when the eyes move to the left as the head is briskly rotated to the right. So that would be considered a normal response. If the eyes do not move as the head is turned, but passively follow the head and turn in the direction that the head is being moved to, that's considered an abnormal response, and that patient has suffered some neurological impairment. Another type of test that checks for neurological impairment is the caloric ice water test. Sometimes you'll hear it referred to as the cold water test. And what this is the patient's head of the bed is elevated about 30 degrees, and the patient's eyelids are held open while the ear canals are irrigated with ice water. This actually stimulates the semicircular canals, and a normal response would be that that patient would have conjugate eye movements towards the side of the head that's being irrigated, followed by rapid nystagmus to the opposite side. This checks cranial nerves 3, 4, and 8 that they are intact. So absence of this type of an eye movement is considered a positive test, and that the patient is non-responsive to this particular test. So the doll's eyes test and this test are also 2 tests that are performed in addition to other things when a patient is being declared brain dead. Another neurological sign is called the Babinski sign, and this is considered an abnormal neurological assessment finding. The way that you perform this particular test is you use some sort of a pointed object, such as the bottom of a reflex hammer or something like that. And what you do is you actually stroke the lateral aspect of the sole of the foot from the heel to the ball of the foot. And a normal finding is flexion of the toes. An abnormal finding, which indicates neurological impairment, is where you will have extension of the great toe and fanning of the other toes. Now, on babies, the Babinski sign, if you did a Babinski test on a newborn baby,
they would actually do the fanning of the toes and extension of the great toe. It's not considered an abnormal neurological find in an infant because they have very immature neurological systems. So with them, we don't worry about that until they would get to be older. It's something that as their neurological status matures, the patient then will have a normal Babinski when they get to be older. Some other diagnostic assessments that we would do, we've talked about a lot of different types of physical assessment techniques that we would use to check neurological status, but some other things that would be done on patients with neuro impairments and increased intracranial pressure would be to monitor the sodium-potassium levels and also osmolarity levels of the blood. So typically these patients are given hypertonic fluids to try and draw the swelling out of the brain and to bring down that pressure and those types of things. Osmolarity values are considered normal at about 280 to 300. So a lot of times these patients are given medications such as mannitol, and this would help to decrease edema in the brain, and it would bring down that pressure within the brain by kind of, if you want to look at it, drying out or dehydrating that patient's brain somewhat. So the mannitol dosages, it's given in an IV form, are typically regulated based upon the serum osmolarity values. Another thing that it's important to do is to monitor the ABG values on the neuro patients. If they are in a comatose state, obviously, and not respiratorily stable, they're going to be on a ventilator. And patients that, remember, have, we try to measure ABG values and keep certain things stable for the patients to decrease pressure within the brain. So typically with neuro patients, you want to keep the oxygen levels on the high side and you want to keep the carbon dioxide levels on the low side. This will promote cerebral vasoconstriction. So we try to promote that to the point where we can still have a good cerebral perfusion pressure. Remember, if the values of the O2 get too low, where the patient has hypoxia, or the values of the carbon dioxide get too high, then that patient can actually develop cerebral vasodilation, which can add to that increased intracranial pressure and make the problem even worse. So other diagnostic tests are going to include CTs and MRIs, and of course, just a reminder to always check BUN and creatinine and allergies prior to a patient having any of this type of scanning done. To prioritize the nursing responses for the case study that we had earlier in the lecture, once we got the results of that CT MRI and that it did show left-sided epidural hematoma, this would indeed be an emergency type of situation. Remember, an epidural hematoma is an arterial bleed, so we would want to get this patient prepped and ready to be going to surgery. And obviously this patient would have a stat neurosurgeon consult to meet with the family and that type of a thing. The patient would have a Foley put in so that we could keep accurate INO on the patient, would have electrolytes and those other labs that we mentioned earlier done. If that patient's temperature continued to be unstable, the patient might require a hypothermia blanket. And in addition to the mannitol that we talked about earlier, the patient might also be given diuretics, sedatives, perhaps paralytics with intubation, antipyretics to bring down that temperature. Patients that have increased intracranial pressure are high risk for having seizures, so the patient would be given anticonvulsant meds and also H2 blockers and vasoactive meds to support the cerebral perfusion pressure. Pre-op meds before that patient would go down for the surgery would include steroids to try and decrease inflammation. So perhaps Decadron would be a good example of that. We talked about the use of mannitol earlier. And patients that are neurologically impaired or have been given large doses of steroids are always at risk for GI upset. So Pepcid would be another med that patient would be given. Typically a craniotomy is going to be done in order to insert an intracranial pressure catheter, and the patient after the surgery then would go to neuro ICU, and typical post-op meds are listed there for you. that patient would come back post-op on a ventilator until the patient was stable and the intracranial pressure value was back to more of a normal value. So remember, if that patient would come back with a ICP device, monitoring device in the head, that this is considered, anytime that this needs to be manipulated, it needs to be done with a sterile technique, because it is a direct invasive line directly into that patient's brain. This is an example here of what an ICP monitoring device would look like. It's also known as a ventriculostomy. And these are actually fiber optic catheters that are zeroed in before they're inserted into the brain. And then they read out on a monitor where you can actually see waveform patterns based upon the ICP readings and different things like that. So it's similar, I guess, in theory to what we do with Art lines or Swan-Ganz catheters to monitor hemodynamic status and volemic status within the body, only this is checking for ICP measurements within the brain. This is just another example of an ICP monitoring device, showing you down at the bottom of the slide there the waveform printout. And there are different waveforms that you would see with a patient that had this device in, and depending on what the waveform pattern looked like could indicate if that patient was having a normal ICP patterning going on, or if that patient had ischemia or some sort of brain injury and insult. And then this is going to read out a value to let you know what the ICP reading is on that particular patient. Post-op meds for that patient while they're in the ICU for increased ICP are listed there for you. Mannitol, we talked about earlier, would be given to help decrease the edema within the brain. An important thing with mannitol, since it is going to, you could say, dehydrate the brain, is to monitor INO hourly with a urimeter on the Foley bag with these patients, as well as looking at urine osmolality and specific gravity and those types of things. This needs to be used with a special filter, and it tends to crystallize, so that's an issue with mannitol. Decadron, we talked about, was a steroid to decrease edema within the brain and to decrease inflammation. And remember, anytime we give large doses of steroids, we should combine that, and that patient should also be on some sort of gut med, an H2 blocker such as Pepsid. Lasix is also another drug that will help to decrease edema within the brain. We talked about the patients being at high risk for seizures, so Dilantin would be a good drug of choice for this patient. Remember, there are issues when Dilantin is given IV. It can cause hypotension, cardiac arrhythmias, and it also precipitates with dextrose solutions. So make sure it's always given with a normal saline flush before and after, or run in with normal saline bag solution if you're not going to flush it before and after. You can give it in a separate line that's a saline line. The other thing that's done with patients with increased ICP and brain insult and injury is they're a lot of times put into a barbiturate coma. This reduces the metabolic demands within the brain, and probably two of the most common meds used are pentobarbital or Nembutal to put that patient into a barbiturate coma. Once that patient has an ICP device in, you'll see variations in the ICP on the monitoring screen, and these variations can be related to subtle things such as coughing, suctioning the patient, airway obstruction. If that patient was off of a vent and did a Valsalva maneuver where they were bearing down, that will also increase ICP. If the patient would have vomiting, that increases ICP. And anytime the patient has muscular exertion, tension, range of motion exercises, those types of things, that increases ICP. We talked about earlier that high CO2 levels increase the ICP, and decreased oxygen levels increase ICP. Also, position changes can increase it, stress and emotional upset, pain, and any type of noxious stimuli. So just give some examples of increased ICP. Some calls for nursing with these patients are listed here. altered cerebral tissue perfusion, thought processes, ineffective breathing patterns, and risk for infection. We talked about one way to control ICP was through the airway. The patient, if they're on a vent, the gases can actually be manipulated by the vent settings in order to keep the PO2 over 60 and to keep the CO2 less than 30 to 35. And remember, the reason for that is high oxygen levels and low CO2 levels tend to cause vasoconstriction, which would help to decrease all of that extra pressure within the brain. So we want to keep the patient somewhat vasoconstricted, but we don't want to vasoconstrict them to the point where they're going to have anoxia to the brain. So what we keep a very close eye on then is the cerebral perfusion pressure values so that we can keep that patient vasoconstricted but still allow an adequate CPP so that we know that the patient is receiving enough oxygen to the brain. Remember to always hyperventilate pre and post suctioning with patients that are neuro patients with increased ICP. Limit the suctioning because that does increase ICP values, and the patient's head of the bed should be elevated at about 30 degrees. Controlling the ICP with the neuro assessment can also, another important piece is to do very frequent assessments on the patients for those subtle neuro changes. So every 15 minutes you may be doing a neuro assessment on a patient back in a neuro ICU. And part of the assessment would also include to note what the Glasgow Coma Scale was, vital sign changes, changes in level of consciousness, orientation, pupil response, and motor response. So once again, don't ignore subtle changes, and the speaker notes make a note on watching the neuro video, which kind of helps to explain this whole lecture. On our case study, we're going to say that postoperatively our patient's ICP was 28. So what would be the first thing that the nurse should do? Remember, always assess the patient first. So look and see if the patient has any neuro changes, what the level of consciousness is. Remember, this is a very high value because normal was between 5 and 10. Check the ABGs if that patient's on the vent. And this would be an indication where the patient's physician would need to be notified if that ICP stayed consistently at that high of a level. Other interventions that can be done to try and keep the ICP down a little bit are to limit visitors, to try and keep the room dark and quiet, keep that patient from straining, coughing, vomiting, keeping the head of the bed elevated 30 degrees, keeping the neck straight, doing fluid restrictions on that patient, and remember, hypertonic or solutions are going to be the best for those patients. So examples of that would include D5NW or D5.5 normal saline. These will help to decrease ICP. Complications of increased ICP include brainstem herniation, which we talked about earlier. The patient, due to pressure on areas of the brain, may develop diabetes insipidus. And there's always risk for extreme dehydration with this particular disorder. Or the patient may develop syndrome of inappropriate ADH. So with this syndrome, remember this was from the endocrine lecture, water is retained, and that can result in hyponatremia and expansion of the extracellular fluid volume. For those patients that are in a comatose and unconscious state, important measures are to maintain airway clearance, give them eye care. Remember, they don't have a blink reflex many times, so they will require eye drops, like artificial tears given every 4 hours to keep the eyes moist and to keep them from developing eye complications. Also, they're at high risk for pressure ulcers and skin breakdown, so they need frequent position changes every 2 hours. If they have increased ICP and comatose, they're going to have nutritional needs. So typically these patients have a G-tube in or TPN and lipids, those types of things. They're at risk for physical mobility issues and DVTs and all those types of things. So when these patients do become conscious to the point where they can try to start foods again, they should have a swallow study done to make sure that they are going to not have issues with aspiration. Remember, those patients that have had severe neurological trauma are going to most likely go through extensive rehabilitation. It may include speech therapy in addition to physical therapy, and also occupational therapy. The patients may have permanent cognitive functional changes where they may have to learn how to walk, talk, eat all over again from the beginning. And remember that many patients that have had severe injuries do not return to the same cognitive level that they were before the injury. We want to talk a little bit about persistent vegetative state. For those comatose patients that have had severe neurological injury, a patient may persist in a persistent vegetative state. This is an irreversible coma where the patient is unaware of their environment, unaware of themselves. They've had a significant loss of all cognitive functioning. They may still have some sleep-wake cycles and have the ability to do things like chewing, swallowing, and coughing, but they don't interact with the environment. They don't do good eye contact, and they don't do good with tracking objects, people, those types of things. So probably a very common patient that suffered from this, and it was actually in the news back in 2005, was Karen Schiavo. This was the particular case that went to court. The husband wanted to take the patient off of nutritional life support. The parents wanted her left on her G-tube feedings, and the husband took it to the court, who ruled in favor of the husband, and her G-tube was removed, and tube feedings were stopped, and the patient did eventually die. So that's probably one of the most common or the most notorious cases that we've had for a patient that's in persistent vegetative state, where a family member did not want that patient kept alive by artificial means, even including food. Probably one of the other most cases that are the most familiar would be the case of Karen Ann Quinlan, and this was back in the mid-1970s. And with this particular scenario, the patient's family went to the Supreme Court to have her ventilator discontinued and her feeding tubes stopped, and allowed her to die. So when we talk about advanced directives and all those kinds of things, a lot of that actually stemmed out of the Karen Ann Quinlan case. So in your speaker notes is a website you can go to if you'd like further information on this. For those patients that have had a traumatic brain injury that's led to brain death, this is different than persistent vegetative state. A patient that has been declared brain dead has irreversible brain damage of all brain functioning. That patient has no motor reflex movements at all. The pupils are fixed, dilated, and not responsive. The patient will have a flat EEG, will have absent ocular response, and persistence of comatose symptoms and those types of things. In your speaker notes, I've typed quite a bit of information from a conference that I went to by Life Connection. This is just a wonderful conference. If you ever have a chance to go to one, they typically have one twice a year in the Toledo area. It's I learned a lot of new information, and I would highly, highly recommend to go to one if you get the opportunity. Once you graduate and you have to start getting continuing education units, this would be a great way to pick up some hours towards your CEUs. One thing that is stressed at the conferences is that, remember, patients can be declared dead by brain death or by cardiac death. So if the patient is declared brain dead by brain death and all the criteria are met, and if that patient has wishes to donate organs, then that's what will be done for that particular patient scenario. So read through your speaker notes and find out a little bit information on that. Life Connection actually arranges for the care of that patient until the organs are recovered, and then the Life Connection nurses and doctors will order meds, treatments, vent settings to sustain that patient's organs until they can be matched with the recipient. So this can last from several hours to a few days, depending on where all the organs are going to be donated. What happens is actually the transplant teams from other areas of the country fly into where the patient is in order to receive the organs. So one patient could potentially donate, heart, lungs, kidneys, liver, skin, bone, all sorts of different things, and these different organs could be going out to a wide variety of different areas of the country, depending on the donor list and that type of thing. So, like I said, these patients are maintained on life support through Life Connection. They would be still in a hospital ICU situation, but Life Connection nurses and doctors take over care of that patient once they're declared brain dead and the family signs consent for organ donation and that type of a thing. So it's very interesting. I highly recommend to go to their conference. Here's an NCLEX question on neurotopics. A client is admitted with a head injury, so to monitor hypothalamic function, what parameters should be monitored? And if you answered temperature and urinary output, you are correct. And second question is, a nurse is caring for a confused client who has sustained a head injury resulting in a subdural hematoma. The blood pressure is 100/60. The patient is unresponsive. And the most effective position for that client as they transport the patient down to the OR would be answer number 1. Semi-Fowlers would be better than high Fowlers because remember that patient would not probably have good head control, and that might actually, high Fowlers, the patient might have problems with airway, an open airway, and those types of things. So this concludes the first part of the neuro lecture, which basically focused on assessment of the neuro patient. And as we get into the next part of the neuro lecture, we're going to start to look at some other disorders of patients that have neurological problems.